Hello friends, my name is Dr. Ali Singhal and today I am going to show you a case of traumatic cataract. He's a young gentleman of 20 years of age. He was giving history of trauma 5 years back, and as you can see that majority of this cataract is already absorbed. So this is cortical cataract and majority of this cortical matter is already absorbed. All you can see a rim at the superior half and a thick plaque in the center. So I try to achieve anticapsular axis in superior half as there is no anticapsule in inferior half. So after removing this anticapsule, now it's time for emulsification of whatever cortical matter is there. So I try to disengage this superior rim out of the bag with the help of blunt tip chopper and at the same time aspirating it. After removing this cortical matter, now I try to remove this posterior capsular band, posterior capsular plaque. It was quite adherent. So with the fear of getting posterior capsular tear, I leave it over there and try to do irrigation aspiration for remaining cortical matter. After removing this cortical matter, now it's time for this thick plaque because it's quite in center and hampering visual axis. First I try to get a cleavage at 5 o'clock positions. There is one thick band extending to the periphery. So I try to put my visco cannula and try to give a nick with the vana so that I can get a cleavage and I can separate this thick plaque from the posterior capsule. But I was not able to separate it out. Finally I get a good plane at between 1 and 2 clock hours position. So I remove and create a cleavage, and because there were high chances of getting this posterior capsular tear, so I decide to put my visco cannula and kind of visco dissection between this thick plaque and posterior capsule. So I try my this visco dissection technique, putting my visco cannula over there, at the same time swiping this blunt tip cannula to and fro so that I achieve a good separation of this thick plaque. So by doing this maneuver till the periphery, I was able to separate this plaque safely from the posterior capsule. So this is what I learned from this patient, that patience and good separation technique can remove this thick plaque and from the posterior capsule. So it's quite adherent to the 6 o'clock position. So I try to stretch it out. I try to remove it out completely, but it was creating quite stretch at the zonules. So my idea is to put lens in center, and after putting this lens, now I'm more safe zone to move this plaque. So as you can see, this lens is in quite center, and I try to disengage this plaque in clockwise and anti-clockwise maneuver, but it was quite adherent at the base. So I try with vana scissor, I cut this plaque from the base and separate it out completely. So my lens is in quite center, and that central posterior capsule is quite clear, so there is no opacity over there. So after removing this plaque from the anterior chamber, repositing iris back to its original shape, like in the center. Now it's time for aspirating viscoelastic material. So whatever viscoelastic material is there in the anterior chamber, above lens and behind lens. I'm trying to aspirate that. And as you can see, this is the end result of the surgery. My lens is quite well centered and is covered with iris, and now hydration of the main port and side port. Thank you.